notification. There you go. Great. Well, thank you so much for being here today. We're very excited to be providing this content with the help of Abbott. We're joined by Dr. Robert Welch and Dr. Chris Davlantes today. Dr. Welch is a professor, clinical educator in the Department of Emergency Medicine at Wayne State University School of Medicine. Also, he is the director of the Biostatistics and Epidemiology Research Design Group at WSU. He is a member of the Cardiovascular Research Institute and an associate in the Department of Physical Medicine and Rehabilitation at Wayne State University School of Medicine in Detroit, Michigan. Dr. Davlantes is the Senior Director of Global Medical Affairs at Abbott Point of Care. Board certified by the American Board of Emergency Medicine, he has practiced emergency medicine for over 25 years and is a fellow of the American College of Emergency Physicians. He completed his medical school training in 1993 at Indiana University School of Medicine and his residency training in 1996 at University of Illinois College of Medicine in Peoria. Dr. Davlantes has held the position of assistant professor in the Department of Emergency Medicine at the University of Kansas Hospital for the past 9 years. And he is still practicing emergency medicine part-time at Northwell Health Systems Lenox Health Greenwich Village, a freestanding ED located in Manhattan, New York City. So we're very excited to hear a little bit more about management and treatment of mTBI today. And I am going to turn it over to Dr. Welch now. And thank you all so much. And we'll have some questions at the end.
Well, good afternoon, everyone. Well, afternoon in my time zone anyways. I wonder if we're missing any people from Florida because of the hurricane that's coming. Let's see. You can all see this?
Looks good.
All right. Well, we're going to talk today about blood plasma biomarkers to determine the need for head CT in patients with mTBI and kind of discuss this in conjunction with some clinical decision rules, which you're most all somewhat familiar with. This program is sponsored by Abbott, and the content of this presentation has to be consistent with all applicable FDA requirements. I am speaking at the request of Abbott. It's not intended for continuing education. I do have past relationships with Banyan Biomarkers, which of course, some of the pivotal studies were sponsored by Banyan. I no longer have a current relationship with them. I am doing some work with BrainBox Solution, some contract research that's also looking at brain injury predictive modeling. So to get on with it, the current clinical evaluation of suspected patients with mild mTBI, for the most part, you're all familiar with this working in the emergency room. Head CT, most everybody, and I kind of still find that that's a mildly common practice around the country. I think, though, becoming more common is selective head scanning based on clinician gestalt, which may not be the best. Clinical guidelines such as ASAP or the Scandinavian guidelines if you're in Europe. There's other European guidelines too, but clinical decision rules are probably becoming more and more commonly used. So the goal of this, our evaluation of these patients is to reduce CT use without affecting patient outcome. And I think it's interesting to go back and look at the history of some of these clinical decision rules. In my world, the most commonly used one is the Canadian CT head rule. And as a matter of fact, in Michigan, we have some metrics and we have some people looking at us for reducing CT use based on the Canadian CT rule. And I actually get reports from my emergency department and hospital as far as how many CTs am I doing, how many I should not have done based on the Canadian head CT rule. But let's just look back at this quickly. This was actually published in 2001, so almost 22 years ago now. This rule was published. They enrolled over 3,000 patients, but only 2/3 were scanned. So you have to keep that a little bit in the back of your mind. And what they found for the Canadian head CT rule, it had about a 98% sensitivity for clinically important brain injury. And that was kind of a definition they came up based on querying a bunch of neurosurgeons and ER docs. It had a 92% sensitivity for any injury on CT. But what we described as clinically unimportant injury, which could include things like small epidurals, small subdurals, small contusions, and small subarachnoid bleeds, it was only about 74.5%. And of course, we don't know about the 1/3 of the patients that were scanned. Those patients, they had undergone telephone follow-up, and if the patient was said, okay, I'm okay, they considered that a negative CT, but 1/3 of them did not get the actual gold standard CT. Now, if we look at this in a little bit different and maybe a more clinically useful way, in Europe, this was done in the Netherlands. They looked at the performance of various different CT decision rules among patients with head injury, and they also enrolled quite a large number of patients in this study. Now, they didn't differentiate clinically insignificant versus clinically significant brain injury, and they also included skull fractures in their positive CT group. So you have to take it a little bit with a grain of salt. But what's interesting here, and these two charts kind of demonstrate the different rules for any traumatic brain finding on CT. Now, this would be ideal over here, if you can see this, where its sensitivity is 100% and specificity is 100%. And the reason it's 100% over here is because this is 1 minus specificity. So this is the ideal up in this left upper corner here. If you look at the New Orleans criteria, we've known this for quite some time now. It's very, very sensitive, but it's got almost no specificity and almost will have you do more CTs than you would if you weren't using a clinical decision rule. The one I'd like to concentrate here is the Canadian head CT rule. It's a little bit more than 80% sensitive in this group of people. So it means you're going to miss probably 15% of the patients with a positive CT. Its specificity, however, is pretty good. It's 45% specific, and that's maybe a little higher than the other studies have demonstrated. And if you look at potential neurosurgical lesions, now this is where I'm somewhat surprised about this result. Most every study, the Canadian head CT rule is basically 100% sensitive for potential neurosurgical lesions. Now, this is only considered potential because some of them had lesions that you could say, yeah, they should be operated on, and maybe they didn't for some reason, but whatever, it's potential neurosurgical lesions. And it was still only about 90%, slightly less than 90% sensitive, and that's a little bit scary. The other issue with some of these rules, and we look at the Canadian CT head rule again, is it can be difficult in implementing them in various practice places. Actually, about 9 years after the Canadian CT rule was actually published, they did an implementation study in Canada and actually found that both the intervention and control sites had an increase in imaging, 13.3% in the intervention site and 6.7% in the control site. And the intervention site this was a cluster randomized trial. Each hospital was either randomized to getting trained and using the Canadian CT rule or not getting trained and just going about their business as usual. So both of these increased CT use over that period. And actually, there was more of an increase in intervention sites, but it wasn't statistically significant. So we can't really say it was absolutely more. Also, not too long ago in 2018, in the Annals of Emergency Medicine, Adam Sharp published an interesting study where they looked at implementing this Canadian CT head rule among a bunch of hospitals in their system, in the Kaiser system. And they found a 5.3% reduction in CT use for these given time points. Now, the given time points were before the intervention of using the Canadian head CT rules versus sometime after, because it takes a little while for these things to actually, once you implement it, to get actually used, as we all know, or at least used correctly. But if you looked at the pre and post average, it was only a 3.8% reduction in use. So even though there was a reduction in use, it wasn't as much as you might think based on the specificity of the Canadian head CT rule. So why do we want to use a biomarker test for traumatic brain injury? Well, diagnosis, it's right now it's basically a clinical diagnosis with a variation of presentations. Depending on the literature you look at, there'll be 7 to 20% will have an acute abnormality on CT when you're talking about people with Glasgow Coma scales of, let's say, 13 to 15. But if you look at people with more like 14 to 15, it's more in the range of 5 to 10%. If you're looking at 15s, most studies look kind of at the 5 to 7% will have an abnormality on CTs. A number of these patients will develop long-term symptoms, the post-concussive symptoms. The other reason we might want to use something like this, a biomarker test, is for prognosis, possibly to follow the clinical progress. It may be considered possibly useful as a surrogate marker for clinical studies of acute therapies. Sometimes trying to find a big change in their clinical outcome is difficult, but maybe we could use them to say, hey, even though they don't look like, they're dancing down the street, that they might have some improvement based on their biomarkers. But for this, we just looked at it for reduced imaging and potential radiation risk. And that's what we're going to talk about mostly today. So the pivotal study, which led to the FDA clearance for UCHL1 and GFAP to be used as biomarkers for brain injury and mild brain injury patients, with the Alert TBI study published in Lancet Neurology. And what we did here, and I was part of this study, was head scans were considered the current standard for detecting brain injury, particularly intracranial injuries after traumatic brain injury, but it was considered to be overused and resource intensive. And the hypothesis was biomarkers, and the plasma-based biomarkers, can predict the absence of intracranial injury and reduce head CT. And the goal was to look at these two biomarkers. This was a prospective study, and it was in Europe and the US. So it's not just couple centers. It was actually done in 22 centers between the US and the European sites. Started in 2012 and ended in 2014. Of course, it took quite a while to get all the follow-up data and the data cleaned and published. It was patients had to be greater than or equal to 18 years old with suspected non-penetrating brain injury. They could have a Glasgow Coma scale of 9 to 15, but as you can imagine, the vast majority of patients had Glasgow Coma scales in the higher range. A head CT had to be done as part of usual clinical care, and that was based on clinicians' evaluation. So some of the clinicians may have used head scan rules, some probably didn't. The plasma had to be drawn and available within 12 hours of injury. And we used pre-specified cutoff values that were based on some prior studies. Now that's kind of an interesting thing, because you can always try to maximize your results to the data you have. But in this case, the FDA made it imperative that we pre-specified cutoff values as positive or negative. So we couldn't go back and guess at it. And how this was actually done, if both UCHL1, which is a marker of neuronal cell injury, or GFAP, which is a marker of glial injury, had to be below the cutoff values to be considered negative. So any one or both that were above or invalid results. So if they were above clinical values, either one or both, it was considered positive. And that would then say, a positive test, how did that correlate with CT? If you look at the results here, that mean age is about 48.9 years, and that's fairly consistent among many of these brain injury biomarker studies. Interestingly enough, the vast majority, over 90%, were Glasgow Coma scales of 15. There was a few 14s, few 13s, and not too many 9 to 12s. And of course, we don't really think we need a biomarker, a blood biomarker for people with a Glasgow Coma scale that present like with a 9. Probably just going to CT all those patients. Most of the patients either had post-traumatic amnesia or loss of consciousness. Again, consistent with many other studies, motor vehicle crashes and falls were the most common mechanisms of injury. In this study, about 70% were white, a little over 25% were Black, and the rest were Hispanic or other unknowns. And again, most were females. Excuse me, most were males. Again, consistent with much of the previous brain injury literature. So of over 2,000 eligible patients, we had 1,959 which were available for analysis. A couple were missing some of the bloods or tests or head CTs for some reason weren't done. And there was 125 positive CTs out of that group for analysis. So of the whole group. And you can see over here in this little table, subarachnoid hemorrhage, subdural hematomas, contusions, intraventricular hemorrhage, some edema, and extradural hematomas were the most common injuries noted. Now here's the nitty gritty of this. The results, if you look at all subjects up here with 125 CT positives, the test was positive in 122, and we missed 3 using the defined positive or negative biomarker test. If you look at people with Glasgow Coma scales of 14 to 15, which was 1,920 patients, of which 113 had a positive CT, we missed those same 3. So that not surprisingly, the test missed the people who were on the less severely injured side of things. However, if you look at what we really want to know, what's the sensitivity, specificity, and the likelihood ratio is negative. Sensitivity, we want sensitivity that's really, really high. Of course, we know we're going to sacrifice some specificity, but we really want high sensitivity. So if you look at the people with Glasgow Coma scales of 14 to 15, it was about 97% sensitive and about 37% specific, you can see here. And the beauty of this, the negative likelihood ratio was 0.07. And we say about 0.1 is or less is good for a negative likelihood ratio. And even with that, our 95% confidence intervals go slightly cross the 0.1 value. The upper is about 0.16, but that's a pretty darn good negative likelihood ratio. That means that if you apply this test to a reasonable probability of, let's say, 5 or 10%, you can basically exclude in the vast majority of the patients the need for a CT. So what did we miss here? We missed, if you look at this picture down here on the left, a very small little subarachnoid hemorrhage in the anterior paraphalx area. I'm going to talk about the one in the middle in just a second, but we missed a tiny subdural over here. You can see this little subdural. Now that would be considered, unless there was clinical indications to operate, that would be considered by the guidelines for neurosurgery on subdural hematomas. It would be considered a non-operative lesion. The one in the middle here was interesting. Looks like a little, maybe a little contusion right here, but it was pretty far peripheral. And, we had to call it positive because it was considered a positive CT for intracranial hemorrhage by our neuroradiology adjudicating committee. But when the patient was worked up, this turned out to be a cavernous malformation. It wasn't actually from trauma. It was a pre-existing condition. Of course, it led to more tests and more workup to finally make the diagnosis. But even though we considered a miss, it really wasn't a missed traumatic injury. Now, we want to get into how do these biomarkers compare to clinical decision rules. And I'm going to go a little bit off base on this because this is one of the earlier studies by Dr. Jones and Dr. Jeff Bazarian, who looked at S100B compared to clinical decision rules. And they looked at almost 680 patients. They were greater than or equal to 16 years of age, and 5.7, again, remember that 5.767%, it's a pretty common number for these type of studies. And they compared them to different clinical decision rules. And what I'd like to show you here in their study, the Canadian head CT rule was only about 80% sensitive. Of course, New Orleans was really high. The S100B, that's another biomarker, was about 85% sensitive. The specificity was much lower than we quoted in some past studies of the Canadian CT rule. It was about 28%. New Orleans, of course, very non-specific, and S100B was actually the most specific of all of them. And when you get down to the likelihood ratios here, none of them were 0.1 or less. But if you look at the area under the curve, that's the area under the receiver operating curve. It's kind of for diagnostic tests if you're not familiar with it. And 1 is perfect and less than 0.5 is of no value. So the Canadian CT rule was barely above 0.5, as was the New Orleans criteria, and S100B was by 0.69, the area under the curve. But if you combine, now this is a little interesting what they did. I don't have time to get into it, but they kind of developed their own rule based on their data. They used their clinical symptom rule with S100B, and that was the most valuable as far as area under the curve. So you're starting to think, maybe using these biomarkers with some type of clinical decision rule is pretty good. We went back and looked at the Banyan study, the ALERT trial. It was the Banyan biomarker study, and to provide full disclosure, we prospectively collected a lot of the information you needed for determining the Canadian CT rule and if it was positive or negative. But sometimes that data was collected by research assistants and not the physician treating the patient. So maybe it wasn't the most ideal. And I'll talk a little bit more about that when we talk about Linda Papa's most recent study. It's probably best that it's done by a physician who's very well trained on this, understands it well, and really truly knows how to interpret the rule. Suffice it to say, if we looked at Glasgow Coma Scale of 14 and 15 patients only, and not using the what they considered the important CT finding, but all study-defined intracranial hemorrhages, the sensitivity of this Canadian CT rule on ours was only 70%, with an upper 95% confidence level here of about 80%. The negative predictive value was still pretty good, 95.5, but not ideal. And of course, when we look back at this, now we don't have complete data for all these patients. We didn't have the 1,900 patients. By the time we could find the ones that met this Canadian CT rules, it was only 919. Of course, using the biomarker assay, we still missed those same 3 patients. But the sensitivity of the biomarkers in this group was 95.5% with a negative predictive value of 99.1. Now, this Canadian CT sensitivity, I will say, is lower than I would have expected. I would say the upper 95% confidence level is more what I'd expect with this type of study. This just came out earlier this year that looked at glial, and which is the glial cell as a GFAP, and neuronal cell UCL1 biomarkers, excuse me, compared to clinical decision rules. And again, with the primary outcome or the main outcome of need for CT or CT positive with mild traumatic brain injury patients. This was published in JAMA Network Open, and Linda Papa in Orlando, Florida, was the principal investigator and the lead author in this study, and she is extremely well known in the world of brain injury biomarkers. She's done a lot of work with this. Interesting enough, she was also worked with Ian Steele on the Canadian Head CT rule years ago, so she's quite an expert in both of those areas. They enrolled 349 patients that had a CT. They enrolled more than that, but some of them didn't get a CT. So their final N was 349. Of course, like our studies, 90% had a Glasgow Coma score, scale score of 15, and 7% had a positive CT. Again, in that 5 to 7% range for the people with GCS of 15. They had the physician at the time of seeing the patient determine the results of the Canadian Head CT rule and document it in their note so they could get actual data. And Dr. Papa really thinks that's absolutely important to have a physician with primary care and really good knowledge of doing the Canadian CT head rule. You know, they didn't have the largest numbers, so the sensitivity, even though it was 100%, look at this lower 95% confidence interval. It's about 82%. So we know nothing's 100%. We know even from Dr. Steele's early work, it wasn't 100% sensitive. Specificity, again, like 33%, which is pretty good. Now, what this means that we can probably reduce our CT head use by maybe 33% if we do this Canadian head CT rule. If you look at GFAP, UCHL1 panel, it's 100% sensitive, but it was less specific. But they used a little different cutoff values than the FDA approved ones were. What she and her colleagues determined was from all the biomarkers, GFAP on its own had the best area under the curve of 0.83. But with GFAP added to the Canadian CT head rule, the area under the curve improved to 0.88, so close to 0.9, which is pretty good. And her conclusion was that the combination of a biomarker and the Canadian CT rule, they both complement each other. Now, this is one thing I found interesting, nested within her study, and this has been one of the biggest complaints about the biomarkers, or the biggest questions, is do you need them, or can you just do any of the head scan rules you're interested in, or or you feel comfortable with? So she queried for every patient how comfortable they felt with using these various different rules, and do they use the rules regularly? And if you look, look up here, with the Canadian CT head rule, comfortable or very comfortable was what, 47 plus 14%. So, well over 50% felt comfortable. Same thing with the New Orleans criteria and with the Nexus 2 rules. But a few felt uncomfortable or very uncomfortable, like 15% in the Canadian CT rule, 14% in the New Orleans criteria, and interesting, 25% with the Nexus 2 criteria, excuse me. Also, what I thought was very interesting is how regularly do you use this rule? And if you look at the Canadian head CT rule, only 26% said they used it regularly. About 50% said they used the Nexus rule, and only 16% used the New Orleans criteria. And I would basically say that there's really no room to use the New Orleans criteria anymore. It was very interesting and very good when it was developed, but its specificity is just to use. The other thing is, the question is, will physicians accept it, or do they think a blood test would be useful? Now, remember, this was only done at her own institution, but in her institution, 86% of the treating physicians felt the blood test might or would be useful, and only about 13% said probably not useful. So what do we really need, I think, to get this into clinical practice is a rapid portable test that's got high sensitivity, good specificity. We're still going to do some negative CTs based on the biomarker test, but hopefully we can reduce it by the 30 to 40% range. It has to have a high negative predictive value and a high negative likelihood ratio of 0.1 or less, like we talked about before. Here, we're starting to look at this, and Jeff Bazarian and colleagues published an article on accuracy of a rapid test using this GFAB, that's glial fibrillary acidic protein, and UCHL1, which is ubiquitin carboxyl terminal hydrolase L1, to predict intracranial injury. Now, what we did here was we used the alert TBI samples that were frozen in biobank, and looked at the same type of information on the biomarker test, using cutoff values derived for this specific test. And we looked at the GCS of 13 to 15 and the only 15 groups. And interesting, there's also a question of, well, how rapid do these biomarkers elevate? So we looked at a very small subsample of patients, had samples that were collected within 2 hours of injury. They were venous samples. After losing some because there wasn't enough serum wasn't enough blood left for the plasma, We had about 1,900 patients, and it was analyzed on the Istat Alinity platform. And to cut through the chase here, if we go to the subjects with a Glasgow Coma scale of 13 to 15, it was 95.8% sensitive, pretty similar with only Glasgow Coma scale of 15 patients, which is probably the ones where we're going to use this the most would be the 14s and 15s, unless maybe they're intoxicated or some other substance altering or dementia. And, it was pretty specific at the 40% range. And again, the negative likelihood ratio was 0.1 and 0.1. And when you look at the number of patients, there was only 308 who had a sample collected within 2 hours of injury. It's got a lot of technical stuff with a study. By the time you get them consented and everything, it's often more than 2 hours post-injury. But we had 308 patients. It was 100% sensitive in that group, about 35.6% sensitive, and the negative likelihood ratio was 0. However, that due to the small sample, the 95% confidence interval was 0.6, so quite a bit above 0.1. Just because of the small sample size, we couldn't really say much more than that. It's just an interesting observation of that small subgroup. So what did the test miss here? Well, some of these are gonna look familiar, because this one right here in image 1, you see these 2 images, that was the same patient that was missed in the alert study. Image 2, that was the same patient that was, quote, a miss, but was a cavernous malformation, not really traumatic injury. And in number 3, the same patient with that small non-surgical subdural. We also missed, using this test, a very small, you can see here, subarachnoid hemorrhage in the frontal air sulcus, and some small subarachnoid images here, subarachnoid hemorrhages here in this image number 5. None of those were considered operative. On the other hand, we don't want to miss anything, but really that's pretty darn good. And I think probably much better than we would get with the clinical decision rules. Another issue you have to consider if you want to use these type of biomarker tests is the cost effectiveness. And this was some early work done based on the alert data, the results of the alert data. It was independent of our study group and sponsor. And what their main finding was, if you look at patients with mild TBI with a probability of intracranial bleed of 0.1 or about 10%, the biomarker screen test is cost effective at slightly over $300 or less. So that's a pretty high number. When they looked at people with a moderate probability, more like your Glasgow Coma scale that are much lower, about 2/3, about 67%. The screening cost was only the screening test was only cost effective at $73 or less. But quite frankly, if you see somebody, unless you think they're just highly intoxicated or something on that order, if you see somebody with a Glasgow Coma scale of 8, 9, 10, you're gonna scan them. And then we get to the issue about what about these clinically unimportant injuries found on CT that was defined way back in 2001 by Dr. Steele and colleagues. Well, we're finding more and more information as we do more of these studies on these plasma biomarkers. And Dr. Yu and colleagues published an article that looked at plasma GFAP concentrations and looked at those with negative CTs but had positive MRI abnormalities. And of course, they did find some people with negative CTs that had positive MRs, not surprising. And although he didn't develop a actual cutoff value for positive, negative, that's probably going to be a little difficult to do, at least at this state of affairs. But there was definitely a grade of injury that went from, normal CT, normal MRI had the lower biomarkers on average. Normal CT with a positive MRI had on average a higher biomarker level for GFAP. And then when you got to the people with positive CTs and positive MRs, they had the highest GFAP concentration. So there is a gradient there. It's very interesting, and it makes us wonder about what we can use these for in the future. That's yet to be determined. Also, out of the same kind of data set, they looked at CT features associated with adverse outcomes after mild traumatic brain injury. And, sometimes we say, well, you got a positive CT, there's nothing you can do about it. But they were able to find some CT findings that were much more associated with a poor outcome than others. Now, the one thing I would say in this study, they had if I remember right, it was over a 20% CT positive rate. So it was a pretty high CT positive rate. But, that being said, we will be able to use the CT when positive to help prognosticate. There's other prognostic things such as the Marshall score and things like that. But this has a group of different injuries that they can define as being a little higher probability of going on to having a bad outcome. So there is probably a good reason to CT these patients still, even if you find little injuries, nothing that's surgical. So what are the future prospects? Again, is it can we use these in the future? Right now, of course not. But will they be able to use as surrogate markers for these TBI studies to either stratify them when we're enrolling them study or help with outcome measures? Will we be able to use it to follow patients' clinical course? And can we use them past 12 hours since injury? And kind of the holy grail at the moment, can we use them on whole blood? Because right now we don't have a approved point of care test using whole blood. Hopefully that'll happen in the future. These are all future prospects, not by any means indicated at this time in our history. And will these tests be adopted in ED? Will providers order the tests? Do we feel there's good enough evidence for it, which I believe there is at this time? Is there practice gaps? Well, we know this. There's these clinical decision rules which are implemented in various different emergency departments, but not always used. And as a matter of fact, as I alluded to earlier, Dr. Papa's group, that study that she said that she published most recently, she says right in there that even though they have these rules, their basic bottom line is they scan people. They don't really use the Canadian CT rule, and even in her place where she helped develop it. Can the tests impact ED operations and patient throughput? If we can get if we have like a whole bunch of people that are waiting for CTs, can we possibly get these blood tests and say to the patient, your test says it's negative, you look pretty good to me clinically, I don't think we need to get a CT. I think that'll go a long way towards helping throughput. Then, of course, are the patients will they be okay with being told they don't need a CT? And that's where clinical shared decision making will come into effect. And although I did show you an article that suggests these are cost effective if you're using a probability of a positive CT of 10% or less, there's other work being done right now on the cost effectiveness. And sometimes those studies, there's a lot of assumptions that go into them that we may not agree with. In conclusion, CT scan is still standard practice in many hospitals and many emergency departments for the evaluation and management of patients with suspected mild TBI. Clinical decision rules might help reduce CT use, but they're variable in their sensitivity and specificity, and they're variable in their implementation. Blood plasma biomarkers may augment the clinician's ability to reduce CT use, as some of these studies are suggested. We do need a rapid test that's useful in an acute care setting. And the combination of GFAP and UCHR1 are the only FDA approved and FDA cleared blood tests. And we talked about potential future applications. And with that, here's the intended statement of use for the Istat TBI plasma test. You can see that here, but it's basically used in conjunction with other clinical information on patients 18 years or older presenting with suspected mild TBI. That's a GCS of 13 to 15 within 12 hours of injury. And it's only at this time approved to determine the need for CT scan. And a not elevated test is considered a good indicator that CT is not needed. we can't really say anything else about the diagnosis at this time other than the CT positive. And with that, I thank you for listening to this.
Thank you, Dr. Welch. I think I'll go ahead and I'll pause there in case anyone has any questions. Please feel free to use
I'm sorry, I can't
chat
hear.
box.
Let's see.
Am I on mute? Can you hear me?
Let me see if I can fix this.
Let me share my screen. Thank you, Dr. Welch. A reminder, if anyone has questions, feel free to use the chat window or chat feature at the bottom of your screen. I'm going to try to share my presentation. Can everyone see that okay?
Looks great.
Okay, great. I can't see you now, so I can't
Sorry,
see
I
you
had to use
nodding of
mine.
head. Well, thank you very much, Dr. Welch. Again, excellent presentation for those that aren't familiar with the biomarkers. The biomarkers have been studied for a long time, and I think it's really exciting having practiced emergency medicine for over 26 years now, I guess. I think it's really exciting to have something else objective to be able to use in evaluating these patients. My disclosure slide, as was mentioned in the introductions, I am an emergency physician, but I also am the Senior Director of Global Medical Affairs, which is the non-commercial arm, the medical affairs arm of point of care at Abbott. I am still practicing as mentioned in my intro. And I think this discussion is a good segue into some patient scenarios where we can maybe apply this. Where would we use this? And I like this slide. This was a picture I took when I was walking my dogs in the meatpacking district where I live now. And I thought it was interesting that, during the COVID pandemic, tourism just went to zero in Manhattan. Somebody was thinking outside the box, and they took the tourist buses and turned them into double-decker mobile COVID testing sites. And I always thought that was really clever. Again, somebody was thinking outside the box. And I think with the advent of all these technologies, Dr. Welch mentioned BrainBox, there's some ocular tracking technologies out there. We have blood biomarkers now. A lot of things are out there that are being researched. I think it's going to cause us to kind of think outside the box a little bit on how we assess these patients, because we've been doing it the same way for years, basically just going through decision rules, trusting our clinical gestalt. And that's great. And the validation, the studies have been done to validate the decision rules, but they're not perfect. And to put it in perspective for everyone, TBI is a global issue. We see about 69 million TBI patients every year, the majority of which fall into this mild TBI category that we're focusing on right now. Of course, we have other people with moderate to severe TBIs where biomarkers are actively being researched quite a bit, but for the purpose of the study that we're talking about and the test that we're talking about in the blood currently available, it's GCS of 13 to 15. And that's the majority of the ones we see in the ED. And of course, that may vary if you're in a level 1 trauma center versus a community or rural hospital. Those numbers might be different. But in the US, we see about 5 million people every year with TBI. The majority, again, are mild, and the majority of them end up getting a CT, as Dr. Welch pointed out. It's still kind of air quotes the gold standard, but again, CT, while it's really good at picking up a structural abnormality acutely, and it's very good at picking up blood and skull fractures, it really doesn't have a place at ruling in or ruling out concussion, and that's something that's currently being studied. But I think people do tend to fall back on doing a CT for peace of mind, for CYA, whatever the reason is. And I think that there's a place now to maybe use them a little bit more judiciously. We have the Choose Wisely campaign, and there's not an insignificant amount of radiation that patients are subjected to when they're getting these scans. And 90% of the time when we do CTs on these people with mild concussions, the CT is normal. And in the 10% where the CT is abnormal, as Dr. Welch pointed out in the pivotal trial that was done, Alert TBI, they're not anything that require neurosurgical intervention. In fact, only about 1 or 2% of the ones that come back abnormal will require a neurosurgical intervention. Some may require admission, observation, rescanning, but they don't require surgery, and they usually have generally pretty good outcomes. So in the last amount of time we have, I decided to go through some quick scenarios where I think this may be useful, and the one we see very commonly in many EDs are elderly patients who come in altered, and they may be found sitting next to their bed. Nobody really saw them fall without any obvious signs of head trauma. One would wonder, do we really need to scan that patient? If they're on blood thinners, obviously they're a little higher risk, and I think most people would CT them, and I wouldn't argue with that. I think there's a place for CTing the high-risk patients, and those people probably don't even need biomarkers. They probably should just get a CT. But you can imagine applying the decision rules, which Dr. Welch, pointed out, have been around for a long time. They've been very well validated, and I'm not here to tell you to stop using these. I think most clinicians do use them, and they work quite well at reducing CT, but they have to be used properly. A lot of people forget that, the inclusion criteria to apply these rules, one of the inclusion criteria is they have to have a loss of consciousness, and that's sometimes difficult to assess. Patients come in and you ask them, were you knocked out? Well, I think I may have been for a couple seconds. I don't know. I got my bell rung. I was a little dazed. I saw stars. Sometimes it's not really clear cut whether they had a loss of consciousness or not. And then they may have had some amnesia. If you look at this elderly patient who may have dementia, they probably always have amnesia and some disorientation. So it makes it a little bit challenging to apply the rules in somebody who already has a GCS of 14, and that's kind of their baseline. And you obviously see various exclusion criteria, like age younger than 16, patients on blood thinners. So one of the things where I think biomarkers might be useful is in patients where you think the risk is still pretty low, but they're on blood thinners. Even if you do a CT, I think a lot of people are uncomfortable that they might miss something, or they might need a repeat scan or some observation, depending on the mechanism. And I think a negative biomarker combined with a patient that has negative or has positive CT head rule that gets a scan that's negative, I think there's a place maybe to even consider using a combination of the two. But you have a lot of high risk criteria, and this patient obviously has a lot of those criteria. So I think the majority of people are going to scan this elderly patient. We see quite a bit of them that come in, and we see a lot of athletes that come in with repeated concussions. And these patients are tricky because I've seen kids like this and teenagers. I've seen, college athletes, and they lie to you. You ask them if they feel okay, they have a headache, if they were knocked out. They're going to lie to their coach. They're going to lie to their parents because they don't want to sit on the bench. They want to get back in the game. So sometimes it can be challenging, but these patients get their bell rung. They have a little amnesia. But if they come into the ED repeatedly, you wonder, should we really be scanning? I think the younger they are, the risk of radiation is cumulative, and I think that's something to consider. Obviously, if you use the decision rules on this patient, you would probably fall into this medium risk criteria if he had some amnesia. Assuming that he did have a brief loss of consciousness and was a little disoriented. I think that's the gray zone. A lot of people would just observe that patient, maybe send them home with good head injury precautions, maybe watch them in ED for some time. But that's where I think, adding something objective like the decision or the biomarkers to the decision rules might be something useful, where you go through the decision rule, they rule in, if you will, but your clinical suspicion is kind of low. And the other patient we see quite a bit is with alcohol or substances on board. I can tell you in Manhattan, I don't know what it is about edibles, but I can't work a shift without people coming in acting really wacky and, confused. They may or may not have been found on the ground, and we don't know. We don't always get a really good history because their friends were doing edibles and they're altered, or they've been drinking and they're found on the ground. Nobody knows if they really hit their head or if they just passed out from the alcohol. So we get a lot of intoxicated patients, and some have mental illness, and some, it's difficult to assess and get a good neuro exam. I think the majority of people will scan them, but it's really not feasible to scan every single intoxicated patient. So I can tell you what happens in the real world, at least where I practice in my shop. We stick them in the hallway, we get a blood sugar, we observe them, and then we reassess them as the shift progresses, and they metabolize to freedom, if you will. And I think that it's a little bit risky because there are cases that people end up getting observed, they don't wake up like they should, they get a scan later, lo and behold, they've got a subdural. So I think this young healthy patient found on the floor may or may not have had vomiting, may or may not be because of the head injury or because of the tequila, who knows? So I think when you apply the rules on this patient, obviously loss of consciousness, vomiting, that person's going to get a scan. And as Dr. Welch mentioned, the New Orleans rules, maybe they created them for all the people drinking Hurricanes on Bourbon Street. I don't know, but it's a great sensitive decision rule, but the specificity is very low because all you need is a brief loss of consciousness. You can come in with a normal neuro exam, GCS of 15. And if you have any one of these criteria on the right, you're going to get a scan, which leads to the low specificity that it has, which is fine. I mean, we do this and we don't want to miss, as Dr. Welch pointed out, we don't want to miss anything. So it's purposely meant to have a high sensitivity at the cost of specificity. And the biomarkers, again, there are several of them that have been studied. The biomarker graveyard is quite extensive. There are a lot of them that have promise. The NFL is another one that's been being researched quite a bit. And this one's interesting. Neurofilament light actually continues to climb for a couple weeks after the brain injury. I think for follow-up, many clinicians that are in the neurology field that are seeing these people in their concussion clinics are looking at maybe tracking people and following them with measuring that level. The GFAP and UCHL1 are the two that the current test is available on the market that Abbott has, and that's the one that was referred to by Dr. Welch in the alert TBI trial that he participated in. And this is the glial fibrillary acidic protein in the UCHL1, the ubiquitin C-terminal hydrolase L1. And what's nice about them is they have different cellular origins and they have different properties. They have different kinetics. This is the kinetics of all these biomarkers, and many of them linger for weeks. Many of them have very short half-life. So S100 is one that's been mentioned in literature and studied quite extensively outside the US. It's mentioned in the guidelines. Even in the ASAP clinical practice guidelines, they mention S100, but those guidelines were dated back in 2008, and I think they're in the process of updating those. But on low level of evidence, and S100 was the only one out there that was really studied, but there, more have come along the way, and I think the GFAP and UCHL1 seem to have the most promise. And what's nice about it is, again, Dr. Papa is getting quoted here, is the kinetics of it is such that the UCHL1 actually goes up right away, whereas the GFAP takes a little bit longer to rise and stays around longer. So you kind of have the best of both worlds. And the magic window is this 12-hour window. And actually, some of the data seems to be supporting the fact that these biomarkers perform quite well, even out to 24 hours. But the current FDA indication is to draw these within 12 hours of the brain injury. And I think in most places, people do present within 12 hours. So I don't think it's an issue. But what's nice is with the test that's currently available, they both have to be negative, as Dr. Welch pointed out. If either of them are elevated, then it's an abnormal test. So if the UCHL1 is up but the GFAP is not, that's still an abnormal test, and you can't use that test to rule out the need for a CT scan. So I like to think of it as like a D-dimer, and Dr. Welch already pointed out the alert TBI data, but just to highlight it again, you have a 99.3% negative predictive value and a very high sensitivity. He mentioned the 5 cases that were missed, none of which required neurosurgical intervention. And I think for most diagnostic modalities we use in the ED, this is pretty good. I think when you look at troponin, you look at D-dimer, it performs quite well. I like to think of this as a D-dimer for the brain, if you will. It's really helpful when it's negative and your suspicion's low. What I do caution people is I don't think people should use this without discretion. So I do think it should be an adjunct. What Dr. Papa's paper recently suggested, as Dr. Welch pointed out, is the combination of the decision, the Canadian rules, particularly with the biomarker GFAP, seem to perform the best. Actually, the area under the curve was the best. So the reason I say that is when D-dimers first came out, I had residents where I was at University of Kansas that were just ordering D-dimer and everybody with chest pain. And pretty soon we were doing a lot of CT angiograms because they had a lot of false positives. So you have to be careful. I think the place for it is the intermediate risk or low risk patients where you just need a little bit more confidence in not doing a CT scan. I think the high risk patients should just get a scan and shouldn't get a blood test. Just like a high risk patient for PE, if we use Wells criteria, and they have a very high Wells score, we shouldn't even be doing a D-dimer. We should probably just go straight to a CTA on that patient. But on the other end of the spectrum, if they're extremely low risk and have no symptoms and a very minimal mechanism, you can argue maybe they don't even need a blood test or CAT scan. You can use your clinical skills and your decision rules by themselves. So I think it's the ones in between that are in that gray zone where I think this is going to be useful, much like we use a troponin as one element of the heart score, which is another decision rule that's been commonly adopted in risk stratification of chest pain patients. So many people point out the specificity being low. Dr. Welch mentioned the PAPA paper, which did highlight how all the decision rules have specificities in the range of 30% actually, but those have been very well embraced and very well validated. High sensitivity, high negative predictive value, but those decision rules we're currently using also have low specificity. So I think the blood test actually performs the same, if not a little bit better actually with regard to specificity. But I don't view this as a false positive. I think people ask this question a lot. They say, well, 60% of patients are going to get their blood drawn and you're going to scan them and they're going to have a negative scan. Again, the blood test currently is helpful to help you not do a CT scan. It doesn't necessarily mean that if they have a positive blood test that they're going to have a positive CT scan. I think what's happening, and what most of the people researching these biomarkers can tell you, that when the biomarkers are elevated, it probably does mean something. They're probably detecting some injury at the cellular level that's released into the bloodstream that the CT is just not picking up. And Dr. Yui's paper did point that out, that almost 30% of patients that leave with a normal CT actually have MRI abnormalities and follow-up. So I take this with a grain of salt. I don't think it's a bad thing. I don't think it's a false positive. It's more likely a true positive. And I think future research is pointing out that there may be some benefit in using these biomarkers for prognosis and ruling in concussion, but that data is not out yet. And that research is being done and that indication is not there with the FDA. So this test, again, is not to rule in concussion. It's to rule out the need for a CT, much like a D-dimer can rule out the need for a CT angiogram. So again, Dr. Papa has been very well published on this subject in this area, did point out one of her papers, the ability to risk stratify using blood markers and detecting injuries, maybe assessing these difficult patients with intoxication, perhaps polytrauma patients. If I have a really unstable trauma patient, do they need a biomarker? Well, they probably are going to get a pan scan. They're going to get a CT head, neck, chest, abdomen, pelvis. But if they're unstable and they have a positive FAST exam and they're going straight to the OR, I would argue that even a polytrauma patient with negative biomarkers in the trauma bay might actually help the trauma surgeon feel comfortable going straight to the operating room to do damage control surgery and not worry about scanning their head on the way, because you don't have time to scan their head along the way when they're intubated and they're going straight to the OR for their abdominal trauma. So there are so many other clinical scenarios that I didn't touch on that I think this will be very helpful as something to have in our toolbox in the right setting for the right patients, to help assess these patients. So I don't think it's something necessarily across the board, and I don't think it should necessarily replace the decision rules we're currently using. I think in the future, as we get more research showing that the biomarkers may actually help us to determine which patients need follow-up when they've researched this. More than half of the patients who present to our ED don't really get the right TBI diagnosis or concussion diagnosis. And we see these in the ED. We're the gatekeepers that see these people. Over half of them don't get the right follow-up instructions. And over half of them don't get the right follow-up referral to a neurologist or concussion clinic. Again, these biomarkers currently aren't indicated to make those recommendations, but I think that's future state. Perhaps as we learn more about these, it might be able to help us triage these patients and identify, even with this negative CT, because I get patients that ask me that all the time. Oh, my scan was negative, so that means I didn't have a concussion? No, you had a concussion. You just don't have a brain bleed or a skull fracture. So I think that there's going to be some value in that, aiding in the evaluation of these patients, possibly reducing CT, and even helping our throughput and reducing length of stay in a busy ED where other people are getting CT for stroke and trauma and other things. I think your seemingly simple, level 4 patient with an isolated head injury that you think you can get in and out, it's not always an in and out thing, because sometimes, depending on where you're practicing, CT may take a while to get done because of the patient volume, and it may take a while to get the CT report back from radiology. So there is a health economics argument and a throughput argument that can be made as well if we can use these patients or these biomarkers on these patients that we're not too concerned about. That's a picture of the Istat Alinity device. Dr. Welch already showed the IFU. It is for 18 years of age or older. It is only for within 12 hours of the injury, and only in the need, in determining the need to reduce CT. It's also a plasma test, so it does have to be spun down in a centrifuge. It's not currently a whole blood test, but it's a test that is drawn up at a lavender top. You send it to the lab, centrifuge it for about 10 minutes, and then you can have your test results in about 15 minutes. So if you have any questions, this is my email address. You can go to Istat, mtbitest.com, learn more about this. Thank you for your time. I ran out of time, but I hope everyone enjoyed the presentation and learned something new. And I will see if we have any questions in the chat box here. It looks like we do have quite a few. If people can stay over and we don't have a hard stop, hopefully we can answer some of these.
Thank you, Dr. Davlantes. I think Dr. Welch did answer many of them. I think one of the last questions is, are there studies for these biomarkers in polytrauma patients?
Yes, actually, and Alert TBI did have trauma patients, several different mechanisms of injury. There was a Lancet Neurology article actually published fairly recently that actually studied these biomarkers and the ability to predict survival and outcomes in 6 months, and death and survival in severe and moderate to severe TBI patients. So the biomarkers are being studied in a lot of different settings, not just mild, but moderate to severe TBI, polytrauma patients. I will mention one of the things that's one of the drawbacks of S100, one of the other biomarkers we mentioned earlier, is that other things besides CNS injury can cause them to be elevated. So GFAP and UCHL1 tend to be a little bit more specific to the brain, so you won't have that cross reactivity with multiple like orthopedic trauma and so forth. So that is currently still actively being studied.
Great, thank you. And one of the earlier questions was around any data existing about the hyperacute use of these biomarkers in clinical practice. So maybe if you could comment on these biomarkers being, how quickly are they found, and has that been studied?
Well, Dr. Welch, you have some data from that Track TBI and Alert TBI study. Maybe you want to answer that, or is he still with us?
I'm sorry, can you hear me now? My headphones cut out for a second.
Yeah, I can hear you.
The question was about how early. I think the data we have shows as early as like 10 or 20 minutes from the brain injury, and it's still actively being studied. How early can we go? That data is there. And do you have anything else about the hyperacute?
Well, one of the earlier studies that was the progenitor for the Alert trial actually suggested that UCHL1 rises faster than GFAP, and that was the theory for using both of those as a panel rather than waiting for GFAP, which takes a little bit longer to rise. Unfortunately, because of the clinical trials, a lot of these patients, like I alluded to earlier, don't get enrolled as quickly as we'd like them to, because it takes a while to identify them, to get them screened and consented and everything. But when we looked at the less than 2 hour patients from injury, with small numbers, it looked pretty good. Can't really say too much about that because they were relatively small numbers, but the data looked pretty good on those patients. So I think, it's like anything. Once these really truly get into clinical practice, we'll learn a lot more about them.
Got it. Awesome. Thank you, Dr. Welch. If there are no remaining questions, maybe we can close today's webinar. Kayla, you're still on?
Yes, we can go ahead and end here.
Great. Thank you, both of our speakers. I think I resonate the comments, in the chat. This has been a very informative session, and thank you for doing that.